yourself and telling us what it is that you do.
Hi, I'm Francesco, and most people call me Frank. And my surname is Di Chiara. I often say as a joke that it's the same letters as the wine Chianti, Chiara, but people seems always to get Chianti correctly, but not my surname. But in any case, I am a thoracic surgeon, today I am representing myself. I'm based in Oxford, but I'm not talking on behalf of my trust today. And I have a background that goes from lung and heart transplantation. And then I've done general thoracic surgery. I also have then specialized in various modalities of minimal invasive thoracic surgery, including robotic surgery, standard thoracoscopy, and then I specialize further in single incision or so-called uniportal thoracoscopy. I worked basically, my specialization was 50-50 Italy and UK. I have a long-standing relationship with this country that goes back when I was 14, as I was a rugby player for many years, going, in and out of the United Kingdom for sport reasons. So I have a interest in catamenial pneumothorax, which is the pneumothorax that happens during menstruation. That goes back to my early stages of training. The interest was mainly because of a little anecdote. I was studying what we call the Bible of thoracic surgery, which is a book called Shields. There's two big books like this. And as I was studying the chapter on the pleural condition, which is the pleura is the lining of the chest cavity and chest cavity benign conditions, I saw this very little paragraph mentioning the fact that you can have a pneumothorax whilst menstruating. But what was striking to me, there was such a tiny paragraph and this incredibly interesting phenomenon in which during menstruation the lung collapses was basically overlooked by a book that was basically, vivisecting every tiny detail of the pleural conditions. And then he was just saying, well, some people can have menstruation and the lung collapses. Well, let's move on to something else. And since then, and we are talking 15 years ago, I always been very interested in this, and was one of the few when I was taking the medical history of my patients, always asking, did you notice if you were maybe ovulating or menstruating? And sometimes, because these patients are maybe very young, 12, 14, 15, I would get some funny looks from the families. Like, what is this surgeon interested in this? I somehow have some morbid curiosity. And I had to explain far and large about it. And sometimes even I was sort of like dismissed from my mentors, say, well, why did you ask this question? It's just embarrassing. You're embarrassing the patient. And that's the reality of the beginning of my training. And I must say that things have very marginally improved through the years. There is a widespread lack of awareness in the medical professionals. Even the specialists like thoracic surgeon should be the one that know, every single detail of pleural diseases. I must say that like new trainees, they are aware of the existence, but they don't seem to be, particularly interested. They only become interested when they work with me, basically.
So, what would you say in layman terms, what would you
Yeah.
say thoracic endometriosis is?
So, okay. The thoracic endometriosis is a syndrome, okay? It's mainly characterized by a group of symptoms that are related to menstruation or ovulation and or the presence of endometrial cells. But reducing thoracic endometriosis to simply the presence or the ability to prove of the presence of endometrial cells in the chest is reductive. So the symptoms are often related to the timing of ovulation or the timing of menstruation, but are not limited to that, and include cough, shoulder pain, mostly represented this symptom on the right, occasionally on the left, is a very typical pain that comes and goes in like in shooting pain that comes and goes during the day, the days of around menstruation, and is very typically represented by the patient with a gesture like this. They put a hand in front of their chest downward like this, and they put a hand here under the right breast, I would say, and they normally do like this, and that's very striking to me. And that's the most common way they describe it. The pain in the shoulder is something that it's very interesting. It's actually a sign of diaphragmatic involvement because the phrenic nerve that goes to the diaphragm is actually comes from up here in the neck. And so when somebody has something in the diaphragm, feels pain in the neck.
That
So
why it's only on usually on the right hand side and not on the left.
yeah, the reason why it's more common on the right is another of the things we understand very little about. There are some theories that goes along the lymphatic drainage, the venous drainage, because it's more represented on the right, because you have the liver. And you have the idea that maybe the cells might be moving with bowels, and so preferentially going to the right. It is, difficult to understand also because they tend to be more represented just behind the liver. And because the liver is sitting there below the right diaphragm, uh, I think that there's a lot of research needed to do because the left hemidiaphragm is a lot less protected than the right. So a simple distribution of the cells inside the abdomen is not an explanation that satisfies me. Because if I were to spread something in the abdomen, it would definitely go very easily to the left because there's no protection there. Instead, on the right, you have the liver, the falciform ligaments. It's very well protected, the right
Yeah.
hemidiaphragm. So there must be something else. Unfortunately, when we come to thoracic endometriosis, the understanding is incredibly poor. And if you want me to expand on this, there's even very little understanding of how diaphragmatic fenestration happens. So, thoracic endometriosis can be in every aspect of the chest: the lungs, the airways, the pleura, which is the lining of the chest wall. There are two linings. So, the pleura is actually two types. You have the parietal pleura, which is the lining of the chest wall, and the visceral pleura, which is the lining of the lung. And then you have the diaphragm. The diaphragm also is recovered by pleura, but under there's muscle and fibrous tissue. So in individuals with catamina pneumothorax, with the pneumothorax that happen during menstruation, and thoracic endometriosis, we find holes in the diaphragm. Sometimes these holes are lined with endometrial cells, sometimes aren't. That's what I said before, that the presence of endometrial cell does not explain fully what we see. And how these holes create and sometimes even open and close during hormonal cycle, it's yet to be understood because sometimes they're quite sizable.
Wow.
I hope that it's clear enough. I feel that when I'm asked this question, I talk non-stop. I don't want to do an overload of information.
No, it's
Uh,
fascinating. In particular, with how it displays in different areas and it can look different and act differently.
yes.
Yes.
So the spectrum of presentation I've seen is very wide. And I must say that in some cases, I felt having done a thoracoscopy, I will come to diagnostic procedures, but with the latest stage of the diagnostic procedures, doing a thoracoscopy, in someone, I genuinely thought they had thoracic endometriosis because they had abdominal pelvic endometriosis. They had symptoms that were strikingly positive. And I went inside and I took biopsies and I didn't find endometrial cells. I think that we have to review our definition of thoracic endometriosis rather than a histological definition. Histological meaning I find the tissue and then I can say you have the condition. If you have the symptoms, then you have the condition.
Yeah.
This is a position that some say to me that I'm radical, that I'm being radical, and that we cannot accept that if somebody has symptoms, we label them as having a condition. To which I reply, what about depression? Do you
Mm.
have a biopsy for depression? No. Patient is exhibiting some specific behaviors, and then you say they are depressed. So symptoms
Yeah.
do define diagnosis, but
Yeah.
it's a long this conversation,
And
quite a
talk,
medical one.
well, yeah, well, I'm sure we could get, trust me, you and I could have a debate on this. This would be amazing. But you going back to the symptoms that you were talking about,
Yeah.
does that mean one of our members actually asked, does are the symptoms similar to asthma? So that's
Well, okay.
breath or
So
wheeze.
so I would say that I never had any patient with wheezing.
Hmm.
And I think even stretching the definition of thoracic endometriosis, even if you have it inside the airways, is unlikely that will give you that typical wheezing uh, of asthma, which is at the apexes and is triggered by cold weather or by exercising. I've never encountered this, and I think that asthma has some typical features of presentation, and also when you're listening to somebody's chest, the sound of asthma, it's quite typical. So from a clinical perspective, I think if you have a respiratory, maybe for a GP might be difficult, but for a respiratory physician, distinguishing the two conditions is something they can achieve. And also, what they have in common though is the cough.
I was about to go
So
on. I was
cough is in
about to
common
ask you
between
about
asthma
cough.
and the cough is in common.
Mm.
What you normally don't have is the pain. Asthma is not usually painful. I mean, yes, you can have pain if you have a bout of cough that lasts for, let's say, 15, 20 minutes. Obviously, you're going to have muscle pain, but it's a diffuse pain and muscle exhaustion for the constant coughing. And both the diaphragm are working very hard for a prolonged amount of time, and you get that diffuse chest pain. Instead, thoracic endometriosis is a shooting focal pain. So you have like a stabbing shooting pain in a focal point,
Mm.
which is normally at the base of the right chest. That's the most common. So different types of pain, and I don't think wheezing is present in thoracic endometriosis. The cough is actually shared by the two conditions.
About to say, is it shared with us? Okay. And we touched on this before when you and I have spoken, but
Yeah.
we know that one of the challenges that individuals can have is when it comes to speaking to our doctors.
Yeah.
Um, Firstly, the majority of them don't even realize that you can get it. You can get endometriosis in other parts of your body and not just in the reproductive organs. What would you suggest that when it comes to speaking to our doctors, how should I'm trying to think how to word this. I should have written it down. What suggestions might you have to help us when it comes to speaking to our doctors about even just to getting a referral case or a diagnosis of it, but even just to be referred to somebody like yourself who would be able to actually who knows about it?
Okay. So thanks
It's
for
a
this
tough
question because
question.
so first of all, I like to say that having dealt for some time with thoracic endometriosis, unfortunately, this has a bit changed the trust I have in my own profession,
Hmm.
which it was actually much better before I had to deal with this condition because I never had to deal with someone who had 10, 15 years history of being not believed by doctors.
Yeah.
And what I find incredible for me is that even in the presence of an established diagnosis of stage 4 endometriosis abdominopelvic, someone who has this established diagnosis and goes to a doctor claiming to have thoracic symptoms, they are being dismissed. I find this incredible to me, and the fact that they sometimes they're told that it's impossible that it's in the chest, it never happens,
Mhm.
and it is something that it probably calls for a lot of change in the medical profession and the knowledge and the awareness. So, what can be done? firstly, is what we are doing now. So that we are in a new era of medicine in which the patient are empowered to seek out informations, and social media have a huge responsibility to come out with high quality information, to avoid people going on Google and then going being incredibly worried about things and stress maybe unnecessarily. And so, first of all, is seek out information. Second, there is something that a lot of people ignore, that is self-referral. You don't always need to go through your GP. If you have tried to go to your GPs, there is a system that is called self-referral, and the patients are allowed to do that. So this is another channel. And also, I think it's very important to mention that you have seen evidence, or on social media, or you've seen real patients testimonies that their condition exists and have exactly the same symptoms. And sometimes highlighting that a specialist that could help you is a very important, because sometimes I understand GPs are overwhelmed, and they might know to the top of their head 10 cardiologists, because it's a very common referral. But if you ask them, oh, can you find somebody who can see me for potential thoracic endometriosis, they don't know where to start looking, and they might be very frustrating and time consuming to them. So saying, no, actually I know someone, could you please make a referral to them, or to this center, or to this place? And that hopeful also would help a lot.
I think when you mentioned about social media, oh,
Yeah.
I've got that echo that's happening on my computer, so I can hear myself. Um, when you talked about the social media, one of the things that I found when I was just at the beginning of my diagnosis with endometriosis was trying to figure out what was offered out as an opinion and what was factual. And I think webinars like this and speaking to people like you, it helps, because you start to be able to distinguish between the two.
Yeah, it's very important. And I think it's also important to have, to find a source from someone who has hands-on practice,
Absolutely.
and not, you know, because I think that if you are, a specialist, or if you are, even a incredibly knowledgeable individual, like someone who's doing a PhD on this topic, yeah, he might have incredible, valuable information, but not be able to actually help. So I think, somebody who's not just, an expert, but also has the ability to either help you directly or direct you to the people that can help you is the best choice of, who to choose to listen to the advice of.
Yeah. And when it comes to the surgery, talk us through it, because this is one of the things that
Yes.
I'm fascinated with is how it's performed. What's the process of it, and what happens during the surgery? Because we're out, we're unconscious, so we don't know any of it, and we just wake up and get told
Yeah.
what's been happening. And I always think it's really important that the individual, the patient who's having it, actually knows what's going to be getting done to them.
Yeah. So, because you mentioned this thing about knowing what's going to happen, you actually, it is a very good question for me. Because, so when we decided to start this program, we asked ourselves, how are we going to set it up? And because we were fully and acutely aware that we would receive patients that had surgery maybe 2, 3 times before, because that's the common history of these patients, we decided that we will want to do our own initial survey and mapping of endometriosis in the abdomen and in the chest. So how is the setup nowadays? Is that someone goes to a specialist center, they sign a surgical consent that is extremely broad. He basically, I say as a bit of a joke, he goes from clipping a nail to chopping an arm. You don't know exactly what you're gonna wake up with. So that is why we decided that all our patients with suspected thoracic, abdominopelvic endometriosis will have an initial laparoscopy, which is mainly just to map the disease, to see where it is. and bilateral thoracoscopies, which means very simply there is a minimal chest and abdominal axis in which we do an incision that is basically 1.5, 2 centimeters in each side of the chest. We insert a camera and we take a video of all the chest. We take all the lung, the diaphragm, the ribs, and all that we can see, okay, both sides. And if biopsy are required, we take a little bit of the lung, a little bit of the pleura, a little bit of the diaphragm, but these are non-operative procedures. We don't take the entirety of the disease. We just prove the spots and we survey and we monitor, we take, we make a plan. Then also the patient has a laparoscopy in which the disease is normally confirming the abdomen and is the extent of the disease. And also we see the involvement of the diaphragms from below, okay? Then we wake up the patients and we see it in clinic in a couple of weeks. And we tell this individual, so we found this in the chest, this on the diaphragm, this on the lung, this on your abdomen. If you're willing to go ahead with the operation, this needs to be done. And then our surgical consent, at least as we see it, is much more defined because we have seen exactly what needs doing and we offer, surgical treatment based on our findings. Okay. We feel that this is very well received by the patient. We had under our care.
There's a question that's
So,
just come.
yeah, you want to know about technical aspect of the operation?
Yeah, I do, because
So,
I'm
so
just
technical
nosy.
aspect. So there are mainly three mainstream techniques that are around nowadays in thoracics: robotic surgery, standard thoracoscopy, and uniportal thoracoscopy. It's no secret that I'm a fan of uniportal thoracoscopy, which is technically more challenging because you have only one small incision and you have to learn to do all the instrumentation to that single port. It is very elegant. It's certainly technically more challenging. He has, because you only have one incision, he has a trend to have a lot less pain postoperatively. The other two techniques with the robot or with standard thoracoscopy, the number of incisions to the chest is roughly the same. Maybe with the robot, you tend to have one more, so you can have a 4, 5, whilst the standard thoracoscopy 3, 4. The issue with that is that every incision you do between the ribs, you risk to damaging the intercostal nerve. And so you have a slightly higher chance of postoperative pain and also chronic pain. The believers and the people that like the robots, they say that you have better dexterity with the robot inside the chest or inside the abdomen or in any cavity. I have trained in robotic as well. And I think that the main advantage of the robot is in the early stages of the learning curve for surgeons. Once you have gone through the learning curve and you have mastered, either robotic or thoracoscopy or uniportal thoracoscopy, I think the difference become minimal. But certainly for future generations, the robot will be mainstream because initially it's safer and it allows for a steeper learning curve. And if you want to know what the future really is uniportal robots. There is not available mainstream. There are studies. I was involved with research as well with this new technology. It will come, and it will probably be the revolution that thoracic surgery needs. But they're not available mainstream right now at all.
I've heard about them when I was at a
Yeah.
congress actually last year, and they were talking about it, which was
Yes.
fascinating. And there's a couple of questions that have just come up in the chat box. I don't know if you've got
Yeah.
access to it.
No.
The one that I've just seen just now is saying that after diaphragm repair, is there a chance for endometriosis reoccurrence on the diaphragm mesh? I was told by my my words today,
You
thoracic
can say
surgeon.
chest surgeon.
There, I'll say chest surgeon. It couldn't grow back.
Oh, well, okay. So I would say that it can't happen. I think is unlikely. With endometriosis, I feel you can never say never. Um, but I think it's unlikely because the cells, the endometriotic cells, will not have nourishment. So if you have like a strand of endometriotic cell coming from healthy and and vascularized tissue going across the mesh and slowly growing long, and cover it, I think is possible, but we'll need to have blood supply from somewhere. And that blood supply can only come from the diaphragm that you haven't resected. You can't have the cells self-sustaining without any blood supply on top of a mesh, because the mesh in itself doesn't have any blood supply.
I hope that answers it. There's a couple more that have come through.
I think there
And
was one that I wanted to answer that you showed me before this meeting about the timing of diaphragmatic surgery and pregnancy.
I was
That was a
just
very
going on to
interesting
that.
one.
Yeah,
Yeah.
I actually, there was two of our members that asked very similar questions on it, so I did put them both down. I'll just see if I've got them written down, because yeah, here it is. How long should someone wait before trying for pregnancy following a diaphragm repair? And also, are there any risks for pregnancy following diaphragm repair with a non-permanent suture?
So what we have to consider is there a defect or a fenestration? Fenestration is Latin for window, so a hole in the diaphragm, or there isn't. So if there is a defect, a hole in the diaphragm, we have to consider the size, and we have to consider the effect that pregnancy has in the intra-abdominal pressures. When the uterus grows in size, the intra-abdominal pressures rises. There is a redistribution of the intra-abdominal organs, and clearly, if there's a defect in the diaphragm, that could potentially push the bowels through that defect in the diaphragm into the chest, and that obviously is what is worrying somebody who knows they have a problem with diaphragmatic endometriosis. This is actually a very rare eventuality, but also I might argue that there is also very little knowledge of the incidence of thoracic endometriosis. So wherever I have the literature quoting that the numbers are very small, I always ask myself how many of these were actually diagnosed correctly before. I think there's a huge underrepresentation of the true numbers of thoracic endometriosis. I've seen in my practice, when we have a suspicion, we tend to find the patient actually with positive biopsies in more than half of 50% of the cases. And we are supposed to find 5% according to the literature. So, the reality is very different.
But that's
But
going on, isn't it? It's that case of it's completely different what you read and
yeah,
actually seeing it.
and staying on the topic, so if the defect on the diaphragm is sizable and there's a planned pregnancy, it's worth thinking of having it fixed prior to going ahead and having the pregnancy. The risk of the waiting time, I would say, is no less than 2 months, but you have to also to consider that if you are pregnant now, you won't have any increase of intra-abdominal pressure for at least 4 or 5 months. So, one can actually time it with that in mind. It's not immediately you are 35 weeks. Initially the intra-abdominal pressure will be reduced. And so the healing process of the diaphragm is normally considered about 2 months. But that's what we do when I do diaphragmatic surgery. I recommend about 2 months of taking it easy, as we say to the patients, because those sutures need to be completely reabsorbed and be incorporated in the diaphragm. I think someone mentioned also resorbable sutures. I think I never put resorbable sutures in the diaphragm. I always put non-resorbable. And that's what I do, because I feel the diaphragm is exposed to a lot of tension. So I use non-resorbable sutures, so they stay there with the patient. And it's obviously a topic that is not known enough. I feel I can answer based on my knowledge of diaphragmatic surgery. The combination with pregnancy, it's very little knowledge about. So I can only give an advice that's based on my medical knowledge and common sense.
I think though that when it comes to any type of endometriosis, wherever it is in the body, people seem to have a lack of knowledge. However, saying that, more research is coming out every single day from all over the world, and
Mhm.
it's it's channeling that research down to us, the general public, as well as the medical community.
Yeah. Yes, it's reassuring that there is growing awareness, although I feel that the chest is always sort of lagging behind a lot.
Yeah, it's
And
quite a
in terms
taboo
of
thing,
quality of
isn't
life,
it?
yeah.
It's quite a taboo subject, I've noticed. Like when you go and
Yeah.
speak to doctors, they seem to go, "Oh, I'm not going to listen."
I think because of the implications, for example, if you say they have abdominal pelvic endometriosis and you have thoracic symptoms, for example, you should be diagnosed before you fly because you could have a pneumothorax when you are on a plane at high altitude and be struggling for breathing.
Hmm.
So I think this sort of la 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 that happens when people because there is like an attempt to deny the situation and the ramifications of these potential diagnoses.
Mhm.
Because if you suspect somebody has catamenial pneumothorax or thoracic endometriosis, you should ask them, okay, we need to time a pneumothorax, you need to time an X-ray for the next time that you're feeling you have the symptoms or close to your next menstruation, which entails a lot of organization. For example, when I have the patient, I need to time that MRI with their ovulation or that, oh, the work that my secretaries need to do is incredible. Because normally they tell you're already lucky you got an appointment for the MRI, and now you're asking me to time it to a specific day of the month. They don't accept that. And the same would be for a pneumothorax, exactly time with the symptoms or the hormonal cycle of the patient.
Yeah. Yes, I think we can all relate to that. I think the majority of the people that are on the call can relate to that. There's a few more questions and that are on the chat that I'm wanting to actually ask before I stop the recording, but then I will stop it so people can put on their screens and we can actually just have a chat informally.
Yeah, yeah.
Um, there's a few, so I'm just going to scroll back up. I think that that's been answered. I was told about the possible surgery that involves collapsing one lung at a time to get better access to the chest. She can't remember the
Yeah,
name of it.
yeah. So when we do the bilateral thoracoscopy, so the patient will be fitted with a special lumen, but a special tube that makes them breathe. So for any other type of surgery, the tube is only one pipe. Okay. When you do thoracic surgery, it has two pipes. Okay. So we can selectively breathe, allow the patient to breathe on one lung or the other. Okay, so when we operate on the right lung will not be breathing and we slightly collapse, allowing us to see. And when we're operating on the left, we can collapse the left lung or stop ventilating the left lung and operate on that side. So this is common practice for thoracic surgery. We can selectively ventilate one of the two lungs to be able to see inside better. Thoracic surgery wouldn't be possible without the double lumen tube, as it's called in medical terminology.
Oh, it's fascinating. Natalie's asked a question, but I can't even pronounce the word. So I'm hoping, Frank, you can read it. It's just above Sarah's.
Yeah. So what does it say? I can see from Sarah, but I can't see
Um,
chat. Is this one that I need to look at?
yeah, if you go to the chat
Lindsay
bit.
Natalie Wood. Oh, lung collapses. So she means lung collapses like pneumothoraces.
That's it, pneumothorax. Thank you.
Okay, yeah. So, do you know if any studies have been done for a progesterone act? There's no actual studies. If we look at the definition of a study, it would be a very long topic. Probably you have to do a webinar. So when we refer to the medical literature, there are various degrees of evidence. The best one is called a randomized controlled trial, is the best quality evidence. And then at the bottom of the food chain, you have observational studies. Observational studies, as the name suggests,
is that a unit that's been doing something for some time says, "Oh well, let's look back what we've been doing for the last 10 years, and publish our data." And unfortunately, for pneumothoraces, catamenial pneumothorax, and thoracic endometriosis, the majority of the knowledge we have comes from these low quality, low level of evidence studies. And the biggest one that we have is 111 patients about the use of hormonal manipulation or hormonal treatment following catamenia pneumothorax or pneumothorax that's related to the hormonal cycle. The fact that I found very disappointing when I was reading this study is that they didn't mention the type of surgery they did in the chest, meaning they didn't tell me if they had removed the endometriosis from the chest. So they said, yes, hormonal treatment helps reducing the recurrence rate, but they didn't tell me if the surgeries had removed endometriosis from the chest. So that's the level of quality of evidence we are dealing with nowadays. So I don't feel I can advise that strongly anyone. I can only say under my care, the endometriosis in the chest is completely removed, surgically removed, excised. It's not burned, it's not ablated, it's removed. And then obviously, then I can say, maybe 5 years from now, if hormonal treatment helps or not. Unfortunately, nowadays, there's very little evidence to be able to officially advise, personal medical advice on this.
No, thank you for that. I'm going to stop the record now so people can switch on their cameras and ask any questions. So just